Good morning. I'm Eric Linzer, President and CEO of the New York Health Plan Association. I want to welcome you to day 2 of HPA's annual conference, How Do We Ensure Innovation is Accessible to All? We're excited about the speakers and panelists who'll be joining us today, and our sessions will be looking at addressing racial and ethnic inequities in healthcare, as well as efforts to empower consumers through greater transparency. Before we start, we're extremely honored to have Assembly Majority Leader Crystal Peoples-Stokes to help us kick off today's conference. Elected in 2002, she represents the 141st District in the New York State Assembly. In 2018, she became the first woman and first African American to serve as Assembly Majority Leader, the second most powerful position in her chamber. Born and raised in Buffalo, she's the daughter of a school teacher and a sanitation worker. The Majority Leader attended Buffalo Public Schools before earning her Bachelor of Science in Elementary Education and her master's degrees in Student Personnel Administration from Buffalo State College. She also holds an honorary doctorate from Medaille College and worked briefly as a school teacher before joining the Buffalo Urban League and Citizen Action of New York. Majority Leader Peoples-Stokes has a reputation for being a strong advocate who puts people and principle before politics. She's a fearless fighter for diversity in our state and has been an integral part of ensuring that minority and women-owned businesses have a fair chance in obtaining state contracts. Leader Peoples-Stokes also has championed the Diversity in Medicine initiative that has promoted entry into the medical field with academic and financial supports for promising students of color. The Majority Leader has also been a strong advocate of efforts to address the social determinants of health, to build an equitable system, and our member health plans share in that commitment to eliminating racial and ethnic disparities in care by making significant investments to tackle the underlying social, economic, and environmental factors that affect health outcomes. She's known as a consensus builder and has been described as an understanding listener who's willing to work in the trenches to get things done. Majority Leader, thank you for taking the time to join us today, and we are absolutely thrilled to have you kick off today's sessions.
Thank you so much, Eric. What an honor it is to have the opportunity to kick off and bring greetings for your session today. I also want to thank Ashley for her support in making this happen as well. As you know, equity in healthcare has been a priority of mine for years. I know that as a health plan provider, talking about single payer healthcare and legislation like my drug formulary bill isn't a popular discussion. So I agree that we should agree to disagree on that one for now. However, I do also think that every man, every woman, every girl, and every boy, every baby should have the opportunity to achieve their best health. To ensure this and to frankly reduce the cost of healthcare, we must tackle these social determinants of health together. This is not something that can be done in a silo. So we need the health plan associates of the world. We need like-minded legislators of the world. We need healthcare providers. We need the clinicians. And we need, in fact, every man, woman, girl, and boy to be participants in helping us figure out how to tackle the social determinants of health. The lack of doing that costs us all more money and, quite honestly, more lives. The past 17 months fighting COVID has really highlighted these inequities in our healthcare system in New York and worldwide. Those who have suffered the most, especially before the vaccine, were those who were already struggling the most. I believe health begins where people live, where they work, where they learn, and where they play. And if there is no access to clean, healthy food, quality education, stable housing, well-paying jobs, quality childcare, and an affordable healthcare system, we will all remain overburdened. It's just that simple. There is a difference between health equality and health equity. In short, you all get it. Health equity means everyone receives the same standard, while health equity means everyone receives individualized care to bring them to the same level of health as everyone else. It is in the latter that we need to have our collective focus. We need to level the field. We need to level the playing field. And again, we cannot do that in silos. We must do it together. This isn't something that we can handle in silos. We want to make that real clear, because we've been trying to do it in silos for way too long. It's not effective. And that attempt just keeps us in this level of disparate care that we're in. We all have to do our part. Together, we can make New York healthier by being intentional as we tackle poverty, education, hunger, housing, and yes, healthcare. Ladies and gentlemen, we are at a unique moment. We can ensure better health outcomes, and we can ensure better health economics if we do it together. I want to thank you again for this opportunity to share. I trust that you will have a wonderful conference and that you will stay blessed.
Well, Majority Leader, thank you for your insightful comments. And just on behalf of the association, just want to extend our appreciation for your willingness always to listen to our concerns and the work and the hard work of your staff, including Leah. So with that, we're looking forward to working with you and your colleagues in the upcoming session on measures to improve the quality and affordability of healthcare in New York and to ensure that the system is equitable and accessible to all residents. Again, we appreciate you taking the time to help us kick off today's program, and we look forward to continuing to work with you on our shared goals.
You are so welcome. I appreciate the opportunity. I'm sure your session is going to be off the chain great.
Well, we appreciate with you kicking it off. It's going to be a great day. So thank you again for taking the time.
You're so welcome. Bye-bye now.
Well, good morning. I want to thank you all again for joining us, and to Assembly Majority Leader Crystal Peoples-Stokes for taking the time to offer pre-recorded remarks to open today's program. And as she said, today's program will be off the chain. Welcome to day 2 of HPA's annual conference. How do we ensure innovation is accessible to all? Now, in case you didn't catch them, yesterday we had a great panel discussion that examined the healthcare outlook beyond COVID-19, including reimagining how healthcare is delivered, measures to contain healthcare costs, and what we need to do to ensure and address health inequities. We also had a great panel discussion on tech post the pandemic, which looked at the role that technology played in making care accessible to patients during the course of the pandemic and the prospects of helping to address systemic challenges in healthcare going forward. And today we've got several great panel discussions that you're not going to want to miss, and we're glad that you're able to join us today. The first one's going to look at addressing racial and ethnic inequities in healthcare and the imperative for action. And later today, we'll look at the role of transparency in transforming the healthcare system. We also have a great sponsored session by DentaQuest that you won't want to miss. Now, before we get started, I want to thank all of our sponsors again who've helped make today possible, especially our presenting sponsors, DentaQuest, Avisis, and Cognosante. Without them and without all of our sponsors, we wouldn't be able to make this program possible. I also want to thank all of our exhibitors, and once again ask that you take a few minutes over the course of the next 2 days to check them out in our virtual exhibit space. Simply click on the exhibit booth tab on your phone, or if you're on your computer, is located on the left-hand side of the screen. And as a reminder, we've got a great gaming challenge, and we've got a fierce battle atop the leaderboard, but there's still plenty of time and opportunity to pick up points over the course of the next couple of days. As you know, either you'll pick up codes through either meeting requests or requesting information from our exhibitors that'll generate a 4-digit code, or answering some of the gaming challenges during the course of today. As a reminder, the top 3-point earners will receive prizes. The first will receive a $250 Amex gift card. Second place will receive a $100 Amex gift card, and third will receive a $50 Amex gift card. And before I turn today's session over to Dr. Talia Schwartz, I did just want to make a mention about yesterday's sessions that we will have the recordings up later today, and the presentations from all three sessions will be available. So with that, let me turn it over now to Dr. Talia Schwartz, President and CEO of Metro Plus, who's going to introduce and moderate the discussion for today's first panel, Building a More Inclusive and Equitable Healthcare System. Good morning, Talia.
Morning, Eric, and thank you for the opportunity to moderate this session. It is my pleasure to introduce today's first panel and to moderate the discussion that will look at building a more inclusive and equitable healthcare system, including the challenges and opportunities for addressing racial and ethnic inequities in healthcare and the imperative for action. We're going to start the session with a presentation from Sarah Rosenbaum, the Harold and Jane Hirsch Professor of Health Law and Policy and founding chair of the Department of Health Policy at George Washington University's Milken Institute School of Public Health. Professor Rosenbaum has devoted her career to health justice for medically undeserved populations. She's a member of the National Academies of Sciences, Engineering, and Medicine, served on CDC's Directors Advisory Committee and Advisory Committee on Immunization Practice, and was founding commissioner of Congress's Medicaid and CHIP Payment and Access Commission, which she chaired from January 2016 through April 2017. Also with us is Assemblymember Pamela Hunter. Assemblymember Hunter represents the southern and eastern portions of the city of Syracuse, as well as surrounding towns of Druid, Onondaga, Salina, and Onondaga Nation. She is the chair of the Assembly Majority Conference, as well as chair of the Assembly Subcommittee on Women Veterans, which works to expand access to benefits and services and improve job opportunities for women who've served our country. She also is a U.S. Army veteran, honorably discharged with a Commendation Medal and 2 Achievement Medals. Assembly member, thank you for your service. Also with us is Dr. Lavon Ansari, CEO and Executive Director of Community Health Center of Buffalo. Dr. Ansari has been with Community Health Center of Buffalo since 2006, taking the organization from single-site federally qualified health center to a 4-site multi-county, multi-service organization, serving patients across Western New York and Buffalo, Cheektowaga, Lockport, and Niagara Falls. She's also the statewide chairperson of the Community Health Center Association of New York State. Next, we have Dr. Marilyn Frazier. Dr. Frazier is the Chief Executive Officer at the Arthur Ashe Institute for Urban Health, a research associate professor in both the Department of Medicine and the School of Public Health at the SUNY Downstate Health Sciences University, and the co-director of Brooklyn Health Disparity Center. Previously, as Deputy Director and Associate Director of Research and Training, she managed the Institute's community outreach and research programs. She is also a co-leader of investigative research team supported by several NIH and CDC grants that help develop behavioral health intervention models and training curricula for the Institute's award-winning Black Pearls and Different Fates of Health programs. Finally, we have Paloma Izquierdo Hernandez. Paloma is the President and Chief Executive Officer of Urban Health Plan, a network of community health centers located in the South Bronx, Central Harlem, and Northwestern Queens. As the President and CEO of Urban Health Plan, she shepherded its expansion from one site facility in the South Bronx to a network of federally qualified community health centers that includes 10 sites in the Bronx, Central Harlem, and Queens, 11 school health programs, a mental health facility, 2 part-time facilities for at-risk populations, 3 WIC programs, and multiple other grant-funded programs. More detailed information on our panelists is available by clicking on the speaker icon. Welcome to all of our panelists. I will now turn the session over to Professor Rosenbaum before we get into our panel discussion.
Thank you very much, Dr. Schwartz, and it's a real honor to be here with all of you today. Maybe next year we all get to be together in person, which would be lovely. So I have to say that as I was sitting here listening to the introduction, I was thinking about the fact that next year is my 45th year with community health centers. I was a very young legal services lawyer working in California and the southern part of the country. And I had an occasion to walk into one of the early health centers, and I was simply bowled over. I was bowled over, not even so much because of the wonderful healthcare being provided, although it was terrific, but because it defined what today we call diversity, equity, and inclusion long before we familiarized ourselves as a country with that term. And the program has flourished so over all of these decades. It really takes one's breath away, and it still captures the meaning, I think, of health equity for the communities served by community health centers. And it always is so wonderful to be able to be on a panel with health centers that are on the cutting edge of the modern healthcare system and partnering with health plans and other community partners to bring health to their communities, not just better healthcare, but real health. So it's great to be here today. I was asked to sort of set the table for the discussion that's about to happen. And I sat and thought about sort of the things I would throw on the table that hopefully would then lead to some further thoughts from the panel. And I came up with my own personal 7-point plan for greater healthcare equity. And I thought I would tick them off and maybe then amplify on a couple of them as I go. The first one, which of course is such a huge one in New York, it's huge everywhere, but after the public charge litigation, which I'm sure many of you are familiar with, some of you may have participated in one way or another. We did a great deal of work supporting New York and other states on their challenge to the Trump administration's public charge rule. The first thing on my list is eliminating exclusionary coverage rules based on legal status. There are pockets of the United States where some accommodation has been made for people who do not have a legal status that makes them eligible for one of the public insurance programs. I don't need to tell you what this population contributes to the well-being of all of us, nor do I need to tell you, because of course it became so evident and was crystallized so clearly by the punitive nature of the public charge rule, which of course affected people who were legally present, but it led to a whole broader awakening around immigrants generally, I think. But the public health threats to entire communities that are created when we try and exclude people from the healthcare system and from programs that make them healthy. And so that is always at the top of my list. It is probably the hardest mountain to climb in some ways, because as a country, we have entered an era, one we've been in for a while now, that just makes immigration and legalization and a welcoming arm for everybody, so that we don't need so many people trying to come here unauthorized, so that we welcome everybody. We're just at a point where we cannot have this discussion, but we absolutely must have it around healthcare. The second, which I know has been a big issue for health plans everywhere. They've been some of the most effective proponents of this. And of course, the provider networks, including community health centers, have been huge proponents of this, is to come up with policies in Medicaid and in the marketplace that simply guarantee enrollment for a year at a time. If you qualify for enrollment during the enrollment period, you are guaranteed your enrollment for a year. Right now, of course, some states do embrace that concept for children. It doesn't even exist as a state option for most adults. And the stabilization in provider-patient relationships, in healthcare, in feeling secure that you have health conditions that can be managed, and all of the sort of active encouragement to interact with the healthcare system and with other programs comes if people are not worried all the time about whether they have coverage, whether they're going to have breaks in coverage. It's something that those of us with employment benefits really don't experience. Obviously, if you change jobs or move, you might have a transition period. But this issue of not knowing from month to month whether you're going to have coverage leads to all kinds of problems, including problems in establishing enough trust between people and healthcare so that they can sort of strengthen their own relationship to healthcare and be confident that their health can get managed over time. A third equity issue, which of course follows closely on the heels of the second, is eliminating financial barriers to care at the point of service. Cost sharing, we know this from a study that was done 50 years ago that still stands as one of the greatest of the healthcare utilization studies ever done in this country. And everything that the study found 50 years ago is true today. It's just that the situation has gotten much worse, which is that among low-income people, cost sharing at the point of service deters access to necessary care. It's not worth it. It's such a bad idea to try and instill consumer consciousness, which is often the excuse given for cost sharing at the point of service. I happen to work in a building that is owned and occupied by the European Union. The School of Public Health occupies a floor. And of course, I've struck up a sort of a collegial relationship with my building mates. And one of them was telling me the other day how eager she is to get home and get healthcare. She's from, as I recall, Great Britain. And I sort of looked at her unsurprised, and I said, don't you have health insurance in this country? Doesn't the EU arrange that for you? She said, oh, yes, but it's ridiculous. We expect nothing from people at the point of service. This is when we want you to come in, want you to get care. And this is, you can imagine a relatively affluent woman who works at the EU, but who was appalled at the barriers we create when people need to come in, need to get health care, and, may not have $5, may not have $3, are afraid to go to an emergency room because of an emergency copayment. This is just not the way to improve the efficiency and quality and equity of healthcare. A fourth is to, of course, do the kind of work that you all I know are engaged in, which is to eliminate siloed healthcare and social services by building a new generation of health plans and provider networks that have the capacity to move between the two and are funded to move between the two and are expected to move between the two, so that when somebody needs a service, as someone who is in the kind of healthcare encounter that the founders of the Community Health Centers program saw as being the entry point into a much bigger discussion about health. When people are in that encounter and need something that is not what the healthcare system provides, but what social services or nutritional services or an educational program might provide, they can be enrolled on the spot, and the services can be arranged on the spot, and access to these services can start quickly as part of care management, which is really very hard to do if the mission doesn't cover all of these issues. Finally, next is rewarding community-wide health improvement. So we've thought a lot about value-based payment for individual patients. We've thought a lot about value-based payment for individual populations. I would like to see us think about value-based payment for community-wide health improvement. That is to reward providers that are engaged in one way or another, and plans that are engaged in one way or another and community-wide efforts, regardless of people's status as patients of a provider or members of a plan at any given point. The next, of course, is to build multidisciplinary teams, something that I know all of you are involved in. It is such a challenge. It has always been the challenge at community health centers, I know. And I think the more we build care teams that reflect the range of needs of patients and reflect the communities in which patients live and work, the stronger is the relationship between people and their healthcare systems. And finally, I would add measuring progress toward health equity in real time rather than through isolated studies. And that means taking the final step that I began working on 40 plus years ago, again, as a young lawyer, working on federal health policy issues. And that is embed certain amounts, a certain amount of information collection directly into the claims form and not rely on specialized studies. If we don't ask in real time, we won't know the answers that we desperately need to know what steps we need to take to make healthcare much more effective for communities than it is. Thank you very much.
Professor Rosenbaum, thank you so much for your insights. I just want to echo what you said about exclusionary criteria. As we are going through the pandemic, obviously the testing and the vaccination applies to everyone, right? Regardless of their legal status.
Right.
Imagine where we would have been if we applied those exclusionary criteria in the middle of the pandemic. So I think that understanding is very obvious and intuitive. But I think it applies, as you alluded to, the general healthcare and what this means for us when we have exclusionary criteria and some people cannot get this access and treatment for the conditions they have. So before we kick off the panel discussion, I wanted to remind attendees that if you wish to submit a question, to enter it into the Q&A section that you will find at the bottom of your screen. We're going to move now into our panel discussion, and we're going to start with a topic that's near and dear to all the panelists here and to me as well: ensuring equity post-pandemic. Black and Latinx New Yorkers have suffered disproportionately during the pandemic, shouldering a high magnitude of cases, hospitalizations, and deaths, and an outsized financial impact as well. What has the last 18 months taught us about equity of care issues facing the healthcare industry, and what investments are necessary to address these disparities and promote a race equity culture in healthcare? Let's start with Assemblymember Hunter.
Great, thank you. Good morning, everyone. This conversation is very near and dear to me. We just struggled through everything since the pandemic, especially relative to access and equity. And that conversation is just paramount relative to getting to the point where everyone has equity in healthcare is access. We have found, especially through the pandemic, that some places had harder times even getting appointments through the pandemic. And especially finding that broadband was not equitable during the pandemic. So in our rural areas, especially in some of our even urban areas, people were not able to utilize telemedicine if they did not have the appropriate technology. And, you know, all of that goes towards equity. I think the pandemic has shown us where we have lacked and we are far lagging behind. And I know the providers who are on here, I worked at a qualified health center for many, many years. Yeoman's work, you know, that they do, but we're working from behind when we're talking about disparity, especially for populations of people of color who are already mistrusting of the health system and having issues, you know, also accessing care. So, you know, I think we definitely need to think about some of those equity infrastructure issues. That's something from a governmental perspective, we're definitely taking a look at.
Thank you. Dr. Ansari?
Sure. Let me just say I'm so happy to be with this distinguished panel. I'm going to continue the conversation by what really happened on the ground. The way we found out about this disease was through listening to the to the community and our patients. Because if you remember, there was no papers on this disease, none. So it made us as healthcare providers really listen to understand what the symptoms were in order for us to be able to treat them, not knowing that we didn't have anything at the time. So that's the first thing I can say that we've learned in the 18 months is to begin to really listen to our community, because that's the only way we were able to understand what was going on with this disease. The second thing that I think is just as important is that we didn't have a plan. No kind of strategic plan, no kind of emergency prepared plan for communities like mine that was struggling to even just get tests. We were the last to get tests, last to get vaccines. That should not have occurred. So it was very obvious that what COVID has done is highlighted the Black experience of what healthcare really is in real time for those of us that are dealing with the underserved, our communities. So if we've learned nothing else in the last 18 months, is listening to our communities, having a plan that will break through the barriers. I'm at the point where I'm calling at the highest level of pharmaceuticals just to try to get 20 tests. We wouldn't even know where the disease was in the community if we weren't fighting. So learning, having a strategic plan and a plan that is equitable, starting with those of us that need it the most first, is the second thing we learned. And the last thing I've learned and we learned is education. I think what COVID has done is allowed us to actually educate our community on what our bodies are doing. So it wasn't just getting the vaccine and the test, but it's also explaining what if you have diabetes and hypertension, what does that do if I had the vaccine? So we had a phenomenal opportunity to educate our communities on what our bodies do and how they function.
Thank you. Tremendous opportunity, really, from a horrendous situation, right, where we still remember looking for those tests, right, that were not available. People lining up for the vaccines into where we are, and the long journey that we have been through, and still a long journey to go through. And Ms. Hernandez? You're muted.
Okay, there we go. Thank you for having me here. It's great to be with some friends and some new people. From my perspective, and just to build on what Lavon, Dr. Ansari was saying, I really look at this as a failure of government and the healthcare system in general to have been able to not respond the way they should have. Yes, the governor, thank God for the governor who was there every minute of every day giving us information. That was the only source of information we had. But when you look at the healthcare delivery system, it failed, and it failed big time. From not coordinating their ICU beds until way later on in the process, to totally forgetting about the people on the ground. And I always say this, I get that the hospitals needed help, but no one came to help us. So as community-based organizations on the ground, we were left to figure it out on our own. And in the very beginning, we struggled and we fought to make sure that our telehealth services were reimbursed. That was a huge fight in the middle of trying to figure out, we have no patients, everyone's getting sick, what do we do? And government telling us, well, we're not paying you for telephone visits. Well, half of our patients can't do video visits. So explain that one to me. So I think when we look at the whole case of equity of care, we have to really start looking structurally, right? And how is our system structurally developed that creates these huge problems that we all really confronted and really, really struggled with from the very beginning.
Absolutely, absolutely agree. And actually, This statement is a great segue into the next question, which is what approaches would you like to see from various stakeholders, the government, providers, payers, to help tackle the underlying social, economic, and environmental factors that have contributed to disparities in care in general, and specifically during the pandemic? Let's start with you, Dr. Fraser.
Yeah, thank you so much. And it's a pleasure being here with all of you this morning. I think just to piggyback on some of the things that have been said, yes, we have these gaping holes that COVID has brought to the forefront that community members, legislators, and everyone, healthcare providers knew that those existed. And I think it has helped us to see where we can plug those, right? And the opportunities that it has presented. So there are opportunities for us to build infrastructure, for government to think about how do we build the infrastructure and how do we get into communities, make sure that people are equipped with the resources necessary. Dr. Ansari talked about not having a plan. How do we build a plan? How do we become strategic before something else happens, right? Going into our communities, whether we're educating them, finding a way that we are giving reliable information. That's one of the big issues that came forth, that we're not getting reliable information. And the mistrust that's already there was even enhanced and became more dire because information wasn't reliable. But how do we develop structures that can provide reliable information, link people to services, making sure services are equitable, and that funding and resources are placed into communities. I think with COVID, a lot of people started just throwing dollars at certain things without a plan or without a strategy. And we need to really step back and say that, okay, yes, there are disparities, there are inequities within our community. There are social determinants of health that we always knew existed. It's not something new. How do we put more funding in housing? How do we make the housing affordable? How do we make housing to be top quality? When we're telling people to, okay, you need to isolate yourself or you need to be quarantined, and they can be quarantined in a place that's overcrowded and so forth. So we need to really step back and think about how do we put together a strategy that will work at addressing social determinants of health, that's to make sure that education is addressed, technology, as the Assembly member mentioned, that it was kind of like new to some and others just didn't know what to do with it. And so I'm thinking about all those different pieces and coming together with the brain thrust that we have to make us have a strategic plan before something else happens.
Absolutely. Professor Rosenbaum?
Yes. Well, I think that the points have been, sort of driven home, and I particularly resonate to Marilyn Fraser's point and to Paloma's point about the fact that what we're dealing with here are real structural inequities that prevent us from acting on the evidence we've got. I mean, the pandemic has done, if the pandemic did nothing else for us, and I forget if it was Paloma or Dr. Ansari who made this point, it allowed the healthcare system to interact with people and help them understand their health and health risks in a brand new way. But all too often then we couldn't act on it because we didn't have the right tools. We couldn't, they weren't insured, or we didn't have the resources, or they couldn't do simple things like get what they needed by a telephone call, or come to a pop-up site, or have somebody spend an extra 15 or 20 minutes with them because everybody was so rushed and there was no money to extend hours or times. Asking health workers to work under, really extraordinary conditions. I mean, all of these things make one wonder whether the most important lesson of the pandemic, which is all the lessons for the future of the healthcare system, is being missed, and we're just sort of in a hurry to put it all beyond us. And I think I'm working actually now on a number of pieces that deal with what have we learned and what are the permanent policy changes that we really need to make as a result of the pandemic if we're worried about health equity. Because every day quite frankly, every day these communities have pandemics. It's different kinds of pandemics. If it's not COVID-19, it's another pandemic. And they've been invisible to us until one that was worldwide and affected everybody. And we either are going to learn from it or we're not.
So we're talking about needed investments. We're talking about infrastructure that needs to be built up. How will we know that we're making progress, right? What are the measurements that we should be using to say we're making progress towards more equity? So why don't we start with Ms. Hernandez?
That is a really tough question. It really is tough because so many things have to change and have to be measured before you can determine whether you're really making any strides in achieving equity. You have to look at health overall. And I've tried to work at our very community level to try to create a community dashboard with our local planning district. Because if you look at all the data that people get, they get lots of data and it all comes from different places, but nobody looks at that data holistically. And so one of my thoughts was, if you were able to pull the data that the community planning board gets, that the congressional office gets, that the state legislators get, if you're able to pull all that together and create a community-wide dashboard that then directs all those committees that exist in our communities to work towards. So I guess there's a need for real alignment to really define what the goals for each community are, and they may be very different. And then be able to measure those. So it really is, I think there's a lot of data out there, trying to figure out where it is, pull it together, in a interdisciplinary stakeholder process, review that data and determine what is a priority to your community, and then be able to track it. And that's a huge effort that requires a lot of collaboration and a lot of willingness to come together. But I think unless we start doing something like that, we're always going to be measuring in silos and not really making great impact because there's just too much.
That's an excellent point. It ties into the introduction that Professor Rosenbaum covered, right? Not just as we provide healthcare, but as we measure outcomes, right? We have to stop working in silos and come together. The problem is too big.
You know, if I could add one thing, I know
Yes.
we're probably up at time, but I'm sure everybody here remembers that almost 10 years ago now, the United States Supreme Court decided a case that basically made it optional to cover a lot of poor people for Medicaid. And New York, of course, is not one of those states, but many states were. And the most tragic thing about that decision, as far as I'm concerned, and there's in the pending legislation, there's an incredibly critical provision for the residents of people, 4 million of them in states that refuse still to insure them. But the most tragic thing about that was that with the Affordable Care Act, as imperfect as the act was, we were finally sort of poised to stop worrying about so much. It's not by everybody, but we were worried, we were going to get ready to sort of stop worrying every day, every minute about people, whether people had health insurance. And we were supposed to be able to get to a point where we could really plunge into the much tougher issues of healthcare, health equity. And that decision, as far as I'm concerned, has cost us a decade. And I think that it should Build Back Better go through. And if we can close the gap in the remaining 12 states and give everybody a way to get in basic insurance with more affordable benefits and decent coverage, then hopefully we can claw our way back to being center stage on some of these issues. When we can't even figure out how people will pay for their care, even the most essential emergency care, it is so hard to get health care then to become an entry point for so much more. And, you know, God willing, we'll get there before the Christmas break, but it's going to take a lot of work.
Thank you. So since we're talking about a difficult question about measurement towards progress, I'd like to hear from additional panelists. So Assembly Member Hunter, how do we measure progress?
I think it's about being honest with where we are right now. We don't need more task force to understand that poverty is at the root of a lot of the health disparity that we see now. And I think it's being able to have political will to push back against, some of the bigger, more obvious type of economic development, to have investment in our poor. If we don't have equity at just the foundational level of housing, Marilyn said it correct. I mean, a lot of this had to do with housing instability, the eviction moratorium, because we didn't want people out there in the streets, infecting others because we didn't know what it was going to be like. But if we have unstable housing, if we don't have equity in education, we're not going to have access to healthcare equitably. We know that we need to expand on broadband, and hopefully this infrastructure bill will help a lot of municipalities and states, especially New York. We say that we're doing it, but it's not happening. We can comment on everything that's needed, but it's having the political will and putting the resources where Dr. Ansari said it, where it needs to be, the most. We know that in the communities, especially FQHC locations, that they needed money the most. I know from my FQHC, they ended up doing a lot of testing, the drive-through testing, but most all of the money was going to hospitals because people were concerned. They were concerned because so many people were hospitalized, but just the education needed to say, hey, let's get to the point where people understand to the best extent the virus, understand the comorbidity and the health concerns. I mean, that's the level it needed to start at. And we threw all the money at the hospitals, and everyone, I was thousands upon thousands of masks I was buying just to pass out to the community. Basic health needs. You get Band-Aids, you should be able to get masks. If you're going, to be able to get something, we just were not prepared, very ill prepared. But we should have seen this coming. I mean, obviously, we've had other health concerns, SARS, MRSA, some of the other things that have come through that started in New York City, and it kind of blew up and then it fizzled out, and then we, weren't concerned. But this should not have been a situation where we were just caught so unprepared. We were unwilling to make the investment to be prepared for when this happens. And if we don't take care of abject poverty, completely starting from the bottom up, all of our think tanks, all of this wonderful conversation that we're happening will be for naught, because the people who will always need it the most will always be the last to receive that.
Thank you. Thank you. Tough message, but thank you for that. You mentioned broadband a couple of times. And one of yesterday's panels discussed the role of technology during the course of the pandemic. Before the pandemic, investments in digital tools may not have been a major priority, but COVID exposed how vulnerable, as the panelist mentioned, the healthcare system can be without them, and accelerated the use of technologies. How important are additional investments in digital tools to expand capacity and address inequities? Let's start with Dr. Ansari.
Sure, a good question. So as my sisterhoods, I'm going to follow up with connectivity. There's connectivity electronically, and there's connectivity to my soul. So those are two different things. Just because I have access doesn't mean we're connected. So not only are we looking at connectivity from the virtual world, we're also looking at connectivity from a human space. So from our experience of doing telehealth, I can tell you instances where we've saved people's lives because we were able to see what they were living in. We have, this is what I can tell you what racism looks like. We had a young man in his 30s, post-COVID, it was an asthmatic. He goes to the hospital, to one hospital, it said, send you home, can't do it. These are the criteria, you don't meet it. Goes to the next hospital. Now he's 3 days later, quick, he's now sicker, go to 2. The second hospital, same criteria, go home. Young Black male. He goes, I get a call from his mother, he's in panic. And she says, I call him and I can barely understand him. He can't even breathe. I get my doctor, call him, and I'm making this story very quick because this is what structural racism looks like and this is how we die. If she had not telehealthed him, she would not have seen he was laying flat on the bed, couldn't move. We sent the ambulance over there. So to make a long story short, we had to fight with the 3rd hospital to get him hospitalized. We knew that his lungs will collapse within 48 hours. If we had not fought, did not have that telehealth visit where we can see what he's doing, what condition he was in, he would be deceased right now. So there's ways that we do telehealth, but there's also a connectivity of the humanness that comes with not just having the electronics, but not just having access, but being connected to the community. Because I knew as an African-American male, because I have 2 sons, that when they say they're not doing well, that means they're dying. Because most African-American men don't tell you they're that sick. So if we don't understand culturally the space that we're in, we will still miss the mark even with the tools.
Thank you. Well said. Technology is important. It's not the solution for everything we're dealing with. Absolutely. Dr. Fraser?
Yeah, just 2 quick comments. Yes, I totally agree with Dr. Ansari. We can have the technology, but if we don't connect, it's not going to work. One of the things that, when we ask a question about what success looks like and how we measure, we do know what success looks like. I mean, I think we all do know what it looks like, but how do we make it equitable? So whichever hospital that young man goes to, he has good care and it's reliable and it's excellent care. We know what success looks like in education, but yet there are schools that are failing and there are ones that are doing well. And so I think that we have to think about equity and we have to be transparent and be bold in talking about racism, bold in talking about health inequities, and having these conversations help. But then it's like, what do we do with these conversations? How do we have action items that will lead to change?
Thank you. Thank you. Great. I want to switch gears and talk a little bit about building an equity culture. And specifically, how should healthcare organizations look at diversity within their own workforce to promote equity within the healthcare system? And are there approaches to advance diversity, equity, and inclusion in the healthcare industry? Let's start with Mr. Hernandez.
I think every organization, but we're talking about healthcare ones, should start with the leadership looking at what their workforce looks like and how does that workforce look like in comparison to the communities that they serve. I know that as an FQHC, our board of directors have to reflect the demographics of our patients. And I believe that leadership and workforce within our organization should be the same. And we know, and Dr. Ansari and I definitely know, that that is not the case. So I think it's really taking a close look, one from a leadership perspective, and really admitting that I serve a predominantly, whatever you want to call it, Black and brown, Asian community, yet my leadership is not reflected at all of that community. And at least having the realization, I think, is a starting point. I think the other thing that's really important, and so, when just going back to that, it really speaks to people's level of comfort with different types of people. And so understanding that as well, I think, is critically important. Diversity is difficult sometimes because it's not what you're comfortable with, let's say. And so, but that's who you're serving. And so it has to be reflective of that. I also think that workforce, you have to start ingraining within your workforce the values of diversity and inclusion. And so how you think about hiring people or recruiting people that are value-based in diversity and inclusion and equity really is, we're doing it at our institution. We're going to get a consultant who's going to train our recruiters how to be able to screen for candidates who have those types of values. And I think once you're able to ingrain that into your organization, then I think it starts becoming part of the fabric of your organization. But I think it always starts at the top, and thinking about how structurally, again, you build it in so that it's sustainable and it stays in place over time.
Thank you. Thank you. Assemblymember Hunter?
I think it's an interesting conversation that we have now, especially about the DEI communities, because, in some ways, I think it's getting lost in a way relative to, to being a corporate buzzword. If you look at FQHCs, and not to pick on them because we're, highly represented here today, but they actually have it right. And in the model for the structure of the boards of FQHC, I believe it's 51% of the people who are on the board have to be actual patients of the facilities that are represented. So it forces them to incorporate into the community. And, if we look at that model, and that came from the federal government, I think Senator Kennedy actually put that in many years before, he passed away. He was a big healthcare champion. But if you incorporate that into other models, any board can do that now. If you incorporate that into any model, you wouldn't have to be struggling to try to identify what is the community need, what does the community look like when you already have those people represented in places and on boards and in communities that have a lot of power, or corporations that have a lot of power in the community. I think that it's been a huge wake-up call. We're talking about healthcare, but it's been a huge wake-up call, especially since the murder of George Floyd, that this is the topic of conversation we're having right now. But this is not new. I think these are the communities that have always been there, and we need to make sure that they're accessed and integrated in an appropriate way and purposeful, not because now we're talking about it and DEI is the new kind of buzzword for corporations. This is how it foundationally has happened to where we have been working from behind, and we need to make that change. And we could have been doing it all along, but now all of a sudden it's a priority, and we just need to call that out for what it is.
Right. Yeah, I mean, there were two programs, community health centers and Head Start. And the interesting thing is that the governing board, just to add to what Assemblymember Hunter pointed out, the debate over the governing board provision, which was added in 1975 when the program first became a formal part of the Public Health Service Act, that debate in conference took 2 days. Can you imagine people sitting and debating anything for more than 3 minutes? This was the conference debate about whether the community really deserved to govern itself. And that had been the model. And there was a lot of sentiment for just dropping communities back to advisory only. And Senator Kennedy prevailed.
Thank you. I mean, those are really important points. And to your point, Assembly member's point, and Ms. Hernandez, it's not just about saying what's right, it's ingraining it right in your culture. That's the next step, right? The recognition is important, but ingraining it, I love that word. I think that's very powerful. Since we're running short on time, I want to move us to talk about policy priorities to ensure equity. Are there approaches that state policymakers should be considering to mitigate the disproportionate financial and health impact the pandemic has had on Black and Latinx New Yorkers? And I know we've mentioned this throughout this conversation, but what specifically would you expect from the state? Let's start with Dr. Ansari.
Something very basic is to get a racial equity tool in which you're making these policies on. Because there's an assumption that policies are neutral and that the procedures will be implemented fairly. Those are two separate things. So as the state or the government are making policies and mandating things, we need a racial equity tool in which those policies are actually filtered through to see if it'll harm somebody or it will be a good thing. So at a very basic level, when we make these policies and procedures, which are two separate things, having a racial equity lens that it goes through will help us to, from the beginning, not have these policies that are inaccurate. Because the other thing is, all these structural inequities are done by human beings. They're not done by, animals, they're done by human beings. So if a human being structured it, another human being with like minds, like the majority leader said, can come and make it better. So that would be my basic thing to say. We can get in all the nuances, but the basic thing, we need a racial equity tool in which any of these policies and laws are being structured to make sure that the foundation is laid right.
Thank you. Dr. Fraser?
Yeah, I like the idea of having a tool and somewhere that we can set and a standard that we can have. I also think that we need to listen to the community, listen to the people that are affected by all of the policies that are made and all the things that are going on, because oftentimes it's someone that's probably detached from what's actually going on on the ground that's making the rules and setting the policies. So I think really listening to the community and listening to the people that need those things, and then trying to address those.
Thank you. Ms. Hernandez?
Yeah, I think I would suggest that first of all, I think that poverty needs to be dealt with. I think that at the end of the day, the impact that our communities have had and have felt have been a result, as the assembly member said, of poverty. And we could talk about this till we're blue in the face. At the end of the day, it's all about poverty. So I think that whatever approach is taken, it's all going to get you to that same place. I know that in the communities that we serve in the Bronx, we have a lot of essential workers. And so the essential workers were really hit hard because they had to go to work and they were out there battling themselves, their lives, protecting their families, all of that. So I think if you look at who were those people in Corona, which was very close to Elmhurst, and you saw what happened at Elmhurst Hospital. It was about the amount, the density in housing, how closely people live, how many people live in an apartment. So when you start looking at those things, it kind of starts telling you the story. So I think if you look at who were the people that were affected, what were the underlying conditions that led them to be affected the way they did. Not only will it get you to poverty, but it will get you to housing, and it'll get you to employment and education, and it'll get you to the social determinants of health. And so however we want to look at this, I think at the end of the day, it's about poverty, and everybody's got to figure out and be willing to commit resources into coming up with some kind of solutions, not one solution, many solutions as to how you can overcome this.
So let's talk about solutions on the federal level. So what approaches the federal government should be adopting to impact inequality, specifically in healthcare? Assemblymember Hunter.
That's one level above where I represent, but I would say, most specifically, we need to ensure what I had been mentioned before, and Sarah had spoken about as well, relative to this infrastructure package. I think, we're not just talking infrastructure relative to roads and bridges, we're talking about infrastructure relative to housing and sustainability and viability. We also need to make sure that the conversation is about environmental justice as well. Any development that's going on in our communities, a road that's put up, a bridge that's put up, how is that impacting the livelihood and the lives of the people who live in and around it? And I think a lot of times we don't have those conversations till after it happens. And then we see increased asthma, increased bronchitis. And so I think, being on top in a more purposeful way relative to investments in the environmental justice area, I think is really important. And, from a policy perspective, we have been focusing on ensuring that states keep their rights because, at the federal level, the Supreme Court and others are having conversations, just say, relative to Roe v. Wade. And in New York State, we have codified that. So we need to ensure that states keep their rights. We know what our citizens want. We want to make sure that we're making policies for the people who live here. And I think that gets taken away, especially conversations relative to McCarran-Ferguson, taking some of those things away. So we need to be able to push that back. And, I have a bill, but Sarah had made mention this. It's important that the policies that we're putting in place, especially say we're talking about Medicaid, which a lot of the providers, whether that they're regular commercial plans, whether they're public plans, are taking Medicaid, that the barriers that people face in order to just keep themselves on Medicaid. We do not live in a state where somebody is on for a year. And some of those barriers are unrealistic. If somebody misses a, appointment for a workforce training, or they had a daycare situation, or they didn't have transportation, they'll get dropped from Medicare. This is not the kind of society that we need to live in when we want to make sure, that people have equity in healthcare. Equity doesn't mean dropping. So that's something we can do and make sure in the state that we can do. But definitely push back on any, type of oversight federally, more than what's the pass-through money. Unfortunately, the federal government gives us a lot of money in New York State, and that there are definitely specific parameters that are in place that we need to make sure. But we know our citizens best, but we, in government need to listen to the people on the ground, those providers on the ground. They know who their community are. They know who the people are who they're working with. And it needs to be at the level, lower than when we get to urgent care. It's really that direct face-to-face, primary care. And the majority leader spoke about it. And I'm happy to have, started carrying the lift of the diversity in medicine. But if the federal government could do more to get more money for organizations, for recruitment and training for healthcare professionals, especially in programs like diversity in medicine. If you can see it, you can be it. In our communities, we like to see, providers of color, and there's huge barriers for providers of color to, even be in the space of trying to be accepted in medical school. So the feds could help doing that.
Thank you. And Professor Rosenbaum?
Yes.
Federal.
Well, I think all of the ideas that have been put on the table are the super ideas. And I think the biggest stimulus for these ideas right now is going to be the direction that the federal government takes in the next 2 years, because of the amount of money that will come to the state along with other states. And I think that beyond that, New York State itself and the community. I mean, I'm as a Washington D.C. person who has a daughter in New York City. I watch New York with particular interest, and particularly the New York City area. I watch to see what the cities downstate and upstate also do, and how much they embrace these reforms. Because I think at the end, it's just got to come from the top down and the bottom up at the same time, and government at all levels down to individual council levels. Everybody just has to insist on sort of a reprioritization. I'm sure this is something that Assemblymember Hunter deals with all the time, which is it's not going to change at the top unless it also changes at the bottom. Whether it's through nonprofit efforts or health plan areas, service areas sort of bubbling up within their service area, or local governments. It's sort of got to come from all directions. It's why also I think that we have to figure out payment reform models that reward community-wide health improvement. So we're not just worried about the people who happen to be plan members or who happen to walk into, a clinic for care. We have to worry the way the founders of community health centers worried, the way actually the very first prepaid group plans way back in time worried about their, that was their mission, to think about the whole community that was in their service area, since anybody could be a member at any given time. It's that embrace of the community that's really going to make the difference.
Thank you. Thank you. And I see that Eric rejoined us on the screen, which means that we are out of time. Thank you so much to the panel. A really critical discussion, both to recognize the issue and really take action to address the issue in an effective manner. Back to you, Eric.
Thank you, Talia, and thank you for moderating today's session. And I just want to reiterate and echo Talia's points. Thank you to our panelists, Professor Rosenbaum. I think we'd exchanged emails earlier this week. I told you your former student, Brett Friedman, was very excited about you joining us, and you did not disappoint. Assemblymember Hunter, it's always great to have you joining us. We look forward to continuing these conversations as we head into next year's session. And then for Dr. Ansari, Dr. Fraser, Paloma, I think the big takeaway for me in listening to all of you is really three important points that we take out of this is one, the importance of building a plan. Second, the investments that need to be made, and third, most importantly, the need to be listening to the communities. I just want to thank you three, particularly for the time you carved out today as folks who are on the front line and dealing with these issues. Your perspective was really important and helped make for a really rich conversation today. So thank you all for joining us.
Thank you. We appreciate it.
Thank you very much.
Thank you.
All right, great. So at this time, we'll be taking a short break before our panel sponsored by DentaQuest, which will start promptly at 11:30. That panel will be discussing the need to implement VBC models in dental practices and how health plans can help accelerate that process. So we'll see you back here in about 15 minutes. In the meantime, don't forget about our sponsor and exhibitors. Please take the time to check out the virtual exhibit space, and don't forget to collect those points for the gaming challenge. Thanks, and we'll see you back at 11:30.